Hello? Can you guys hear me? Hello? Hello?
Yes, sir. We're
Okay. Okay, perfect. So let's start our session. So today we are going to discuss some bone tumors, right? So yesterday we discussed Paget disease. We also discussed a lot of like osteoporosis. We discussed osteogenesis imperfecta. But today we will be focused on some bone tumors. Is that right? Hello? Can you guys hear me?
Yes, sir.
Okay,
Yes.
perfect. So bone tumors. Can you guys just see my screen?
yes.
Yes.
Okay. Okay, perfect. So as we already know that whenever we have tumors, so tumor can basically be classified into two types, right? Either the tumor can be benign or either it can be malignant, right? You already know that. So can anyone just tell me the features of a benign tumor and malignant tumor? If I just tell you, just give me a single differentiating feature between benign and malignant tumors of what would you guys say?
The nine tumors are more
Metastasis
broad
would not
than
happen.
they're not fixed. So
Okay.
malignant is more is fixed, and they have a lot of differentiations like changes in skin color or
Okay, so
shape
like the simple one and
color.
like a straightforward, I would say that benign tumors do not spread, while malignant tumors they spread, they invade, right? Can I say that?
Yes.
Okay,
Yes, sir.
so like when we're discussing like tumors of bone, so it can also be benign or malignant, right? But remember, whenever I just use the term oma in the end of a tumor, consider it as a benign tumor, right? Like osteoma, osteoid, osteoma, we'll be discussing that, right? Osteochondroma, right? But whenever I use the term sarcoma in the end, so sarcoma is specifically is a malignant tumor. Is that clear?
Yes, sir.
Yes.
Okay, perfect. So let's discuss our first tumor, that is osteoma. So what do you guys think? Is it a benign or a malignant tumor?
Benign.
Benign.
Okay,
Benign.
perfect. It is a benign tumor. And what's specific about osteoma is that you are going to see osteoma on facial bones. Very important, right? Facial bones. Another thing which is like associated with osteoma, that it's associated with a disease or a pathology which is known as
God.
Gardner syndrome, right? So what happens in Gardner syndrome, like basically it's a topic of GIT, but let me just give you like some of the features. Let me just tell you some of the features which you are going to see in Gardner syndrome. First of all, we are going to have FAP, right? That is familial adenomatous polyposis. That is a lot of polyps within your colon. Is that clear? Or in your GIT, right? Like thousands of polyps, right? In Gardner syndrome. Second thing, yes. Yes. Do anyone knows? Hello?
Osteomas.
Peritoneum
Osteomas.
osteoma.
Okay,
Multiple osteomas.
osteoma. That's obvious that you are going to have osteoma. What's the third thing? What's going to happen to the retroperitoneal space? You are going to have fibroblast proliferation there, right? But that won't be malignant proliferation. Like the retroperitoneum space is going to fill of like be like occupied by extra proliferation of your fibroblast, which can invade and which can disrupt like many functions, right? I'll be just discussing that in the GIT module. Don't worry about that. But one of the feature, okay, that is like fibroblast proliferation in your retroperitoneal, but that won't be a malignant proliferation, right? So here the point which you guys have to remember, that Gardner syndrome, basically syndrome is like group of pathologies or group of events all occurring at once, right? So osteoma is also the part of Gardner syndromes, right? So it's basically a benign tumor of bone, and we are going to have these tumor on your facial bone. Is that clear? Hello?
Yeah.
Yes.
Yes.
Clear.
Oh, okay, perfect. So the next tumor which we are going to discuss is osteoid, osteoma. What do you guys think? Is it a benign or a malignant tumor?
Benign.
Benign.
Okay, perfect. Benign. Yesterday we discussed something about osteoid. If you guys remember, I was just telling you that we have osteoblast And osteoblast basically makes a matrix which is known as osteoid, right? And osteoid further is going to be calcified. Calcium is going to deposit like or mineralized and phosphate, and in turn you are going to have a mature bone. Did you guys remember?
Yes.
Okay,
Yes.
perfect. So it's basically osteoid, osteoma. Like we are going to have osteoid, like for example, if in the bone, if someone is having osteoid, osteoma, so what would be the feature of that? You're going to have osteoids, right? That matrix which is being laid by your osteoblast, right? And this osteoid would be surrounded, like it would be just surrounded by, reactive bone, right? Reactive rim of bone. Like once we have a deposition of osteoid, like the bone in the periphery is going to be like reactive and it's going to lay down some bone. It would just surround the osteoid. But this rim of bone which is surrounding this osteoid is basically known as osteoma. Is that clear? And osteoid, that's obvious, that's some matrix which is being produced by your osteoblast. Is that clear? So it is osteoid, osteoma. Osteomas. Hello?
Doctor, can you repeat this concept, please?
Okay, I'm just repeating it. So osteoid, osteoma. We already know that osteoid is just made up of, your osteoblast, right?
Yes.
Okay. So what happens in this benign tumor, that osteoblast would just go mad. It would just produce a lot of osteoid, right? Normally, osteoblast does produce osteoid. Is that clear?
Yes, doctor.
But the bone which is surrounding, okay, it basically happens in the cortex of bone. You guys already know that. For example, if this is our bone, so we have our medulla in which we have our bone marrow, right? And which is basically known as medulla. Okay, it's the medulla of bone, and we have cortex, right? And the cortex is also surrounded by a periosteum, if you guys remember, right? The connective tissue layer. Is that clear?
Yes, doctor.
So this osteoid, osteoma is going to occur here at the cortex, right? So first of all, what happens? The osteoblasts are going to make a lot of osteoid, right? And as a result of that osteoid formation, this bone would just become the bone which is surrounding this osteoid tumor kind of thing, right? It would just become reactive and it would just form some, a rim of reactive bone surrounding your osteoid. Is that clear?
Yes, doctor.
Okay. Like the idea is really simple. If I'm just making abnormal kind of like benign osteoid, so the bone which is surrounding that osteoid, it would just become like, it would just form a rim of bone, an extra kind of bone which is surrounding this osteoid. That's simple, right? So this rim of extra reactive bone which is surrounding the osteoid is known as osteoma, right?
Yes, doctor.
Okay, so we have osteoid, osteoma. Is that clear?
Yes, doctor.
Okay, perfect. So as we discussed that it's going to occur at the long bone, right? In the long bone, for example, in the femur, and we already know that it's going to, occur at the cortex of bone. Okay. Another point which you guys must remember that basically the size of this osteoid, osteoma is less than 2 centimeters, right? So it's a small kind of benign tumor. You guys should know that. And if like an individual is having this condition and he's experiencing pain, so what happens if you just give aspirin to this individual? The pain is going to be resolved. You can simply imagine that it's a small tumor, so even giving aspirin can resolve the pain which is caused by this tumor. Is that clear? Hello?
Doctor.
Yes.
Okay. So the next tumor which we are going to discuss is, yes, osteoblastoma. Right? So are you guys just following me? Hello?
Yes, sir.
Yes.
Okay.
Yes, sir.
So you guys can here just see the name osteoblastoma. So can you guys just tell me, is it a benign tumor or a malignant tumor?
Benign.
Benign.
Okay, benign. So here you guys can see it's a tumor of your osteoblast, as the name is indicating. But osteoid, osteoma was also tumor of your osteoblast, right? Because osteoid is made by your osteoblast. Is that clear?
Yes.
Yes, doctor.
So almost both of these names or both of these terminology, like they sound similar. So how to differentiate them from one another? So we have 3 key differentiating features which you guys should know. If Osteoid osteoma is less than 2 centimeters, so osteoblastoma would be greater than 2 centimeters. Remember, right? It would be a little bit big. Second, the pain would not resolve by administration of aspirin, right? If you get a scenario and you are confused whether it's osteoblastoma or it's osteoid osteoma, so look towards these things. If the size is greater than 2 centimeters, go for osteoblastoma. If the pain is, isn't resolving with aspirin, think of osteoblastoma. Is that clear?
Yes.
And another point which you guys should remember, as we know that osteoid is a matrix, right? And further, it's going to be, mineralized. So on X-ray, basically, you are going, like X-ray won't able to pick this osteoid, right? So you're going to see like a radiolucent core in osteoid osteoma, radiolucent core. Because your X-ray isn't able to pick osteoid, but it can pick the reactive osteoma as a white. In X-ray, basically bone appear as white, right? Hello?
Yes.
Yes.
Okay, so on X-ray, whenever you see like a reactive rim of bone, like with black kind of, radiolucent core, simply think of osteoid osteoma. Is that clear?
Yes.
Okay,
Yes.
perfect. So let's discuss our next tumor, that is osteochondroma, right? Osteochondroma. Okay, can you guys just tell me what do chondroma mean basically?
Cartilage.
Cartilage, right? And what do osteo mean? Bone, right?
Bone.
So how can we have osteochondroma? So the idea is that it's basically a benign, it's OMA, right? It's a benign tumor, right? So it's a benign tumor of bone, but that bone would be, surrounded by, or you would be having a cap of cartilage over that. Is that clear?
Yes.
Then we are going to call it as osteochondroma. If you have a bone tumor, osteo, and it's surrounded, or it's, you have a cap of cartilage which is surrounding this tumor, we are going to call it as osteochondroma, as it is OMA, so it means it's a benign tumor, right?
Yes, sir.
Okay, so let's just go towards a little bit of embryology. If you guys remember, yesterday we discussed that, for example, if this is your bone, so in the middle you have your growth plate, which is cartilaginous in nature. You guys know that, right? And it's known as metaphysis, right?
Yes.
Okay, above metaphysis we have epiphysis, right? And below metaphysis we have diaphysis, right?
Mm-hmm.
Okay, so remember, if we want a condition that in which we have like benign tumor of your bone surrounded by a cartilaginous structure, so like you can simply think of this tumor would occur somewhere here in the metaphysis, because here we have cartilage, and we want cartilage to surround the bone tumor, right? Then we are going to call it as osteochondroma, right?
Yes, sir.
Okay, perfect. So what happens in this tumor, we are going to have lateral projection of the bone. We are at the metaphysis. It would laterally project. It would just give you osteoma. And this osteoma, like simply you can think of this it would just pull off this cartilage with itself. And in the end, you will be having a bone tumor surrounded by a cartilage known as osteochondroma. Is that clear?
Yes.
Okay, but sometimes we have you can have cancer of a cancer. What do I mean by cancer of cancer, right? Like we'll be just discussing a condition in our reproductive module. So you have a teratoma, right? So what is a teratoma? If you guys remember, it have like a bunch of things. It can have like skin tissues, teeth. It would be having teeth. It would be having hairs and things, right? So, but like it's a tumor, but sometimes inside the tumor, that teeth can have a tumor, right? So it's like a kind of funny thing. So sometimes what happens if you have this tumor, this cartilage in turn can become malignant, and it can end in chondrosarcoma. Are you guys getting me?
Yes.
Like although we know it's an osteochondroma, but sometimes the cartilaginous part of this tumor can transform into a malignant condition, which can result into chondrosarcoma. And as I discussed, sarcoma is a malignant tumor, right? So we can have, like in certain condition, you can have chondrosarcoma of this tumor as well. Is that clear?
Yes,
Hello?
clear.
Okay, perfect. Let's discuss our next tumor, that is osteosarcoma. What do you guys think? Is it a benign tumor or a malignant tumor?
Malignant.
Perfect. It's a malignant tumor, right? Of your bone, right? So whenever we have malignant tumor of the bone, it's simply known as osteosarcoma, right? But it's basically malignant tumor of your osteoblast. Remember that, right? And the peak incidence, basically, you are going to see this tumor in teenagers, right? Teenagers. And it's associated with, like, like familial retinoblastoma. So what is familial retinoblastoma? The idea is really clear. You have a retinoblastoma, you have a gene, which is a tumor suppressor gene, right? Hello?
Yes,
Okay.
doctor.
So let's suppose if you have certain mutation in this gene and this gene get mutated, so simply you can think of, if I'm just knocking down my tumor suppressors, if I do not have anyone to suppress the tumor, it can develop into a tumor. Simple, right? Hello?
Yes, doctor.
Okay. So like familial retinoblastoma, like you can have tumors like in the bone, that is osteosarcoma, and along with that you can also have like tumors of your eyes as well, right? Retinoblastoma. Okay, another thing we discussed yesterday, Paget disease, right? What happens in Paget disease, if you guys remember, you have increased osteoclastic activity, and in the end you have increased osteoblastic activity, right? In the end your osteoblasts were dominating, remember?
Yes, sir.
Hello?
Yes.
Okay, so if the
Yes.
osteoblasts are making a lot of bone, so simply you can think of, if it's, like in the end your osteoblast was just getting mad, it was making a lot of bone, right? So what happens if there is increase, like mitosis, or if you are just increasing, if the cellular division is increased, so increased cellular division, you can have a chance of mutation there, right?
Yes. Right.
Oh, yes. So increased turnover of the cell, there are increased chances of mutation as well. What do we mean by mutation? Like you can simply think of the retinoblast gene, it can be mutated and it can result into osteosarcoma. It can result into a malignant condition. Is that clear? Similarly, radiation can also give you this condition. Why? Because radiation directly can damage your DNA. Once the DNA is damaged, it increases the chance of mutations again, right?
Yes.
And if we have mutation, it can lead to, abnormal mutation, knocking down your retinoblastoma, tumor suppressor gene, which can lead to malignant osteosarcoma. Is that clear?
Yes, sir.
Okay, so what would be the best location where you can see this condition? So that is your knee,
Knee.
region of your knee, right?
Yes.
Region of your knee, or simply I can say it's a distal femur and proximal tibia, right? Distal femur, proximal tibia simply mean knees, right?
Yes, sir.
Okay, so an important thing which you guys should remember is that, like, obviously, as it is a malignant condition, it can lead to pathological fractures. So in the history, you'll also be seeing for pathological fractures. An important thing which you guys should know is imaging, right? So on imaging, there would be a characteristic findings which you guys should pick, right? So you have a UWorld MCQ on that as well. Like we discussed, for example, if this is our bone, right? Let's suppose we have an individual, like it's an individual bone who is having osteosarcoma. So what would happen? You are gonna see a destructive lesion, and this destructive lesion can like move, like it would just tend to move out, it would grow out, and as it is moving out, what would it do? We know we have a periosteum layer, right? We discussed we have a connective tissue periosteum layer. So what happens? This tumor can lift the periosteum layer along with itself. Are you guys getting me? Like if the tumor is going laterally, it would lift that periosteum layer with itself, and it would just give you an angle. Here we have created an angle, right?
Yeah.
What's that angle called?
Codman triangle.
Okay, Codman triangle, because it's a triangle, right? So Codman triangle formation is specific for osteosarcoma. The idea is really clear. Why we are going to have that? Osteosarcoma, malignant condition, it would spread laterally, and as it is spreading laterally, it would just lift off the periosteum layer with itself. It would just give you an angle, a triangle, which is known as Codman triangle, right? Is that clear?
Yes, sir.
Okay, another thing, as we know that it's a destructive lesion, right? It's a malignant and destructive lesion. So you can also have some small bony outgrowth, and it would just resemble as a ray of, light or a beam of light. So that is basically known as sunburst appearance, right? So simply you can just, it would resemble a sunburst on X-ray. Is that clear? Which is going to give you sunburst appearance, which is highly specific for osteosarcoma.
Osteosarcoma.
Is that clear?
Yeah.
Okay, perfect. So this was all about osteosarcoma. Let's discuss our next tumor, that is giant cell tumor, right? Giant cell tumor. Okay. Do anyone have any idea what is giant cell tumor?
Tumor of multinucleated cells.
Okay, multinucleated cells. Basically, you are going to have giant cells, and like it would just resemble like osteoclast, big osteoclast. Simply, you can think of, right? So we are going to have giant cells, and basically, you should know the location where we are going to have like giant cell tumor, right? That's important. So, for example, if we have our bone, we already know that we have a broad plate, which is our metaphysis, and above metaphysis we have epiphysis and diaphysis, right? So this is the only tumor which you are going to see in the epiphysis, right? So epiphysis, you are going to have giant cells, like a big giant cells in the epiphysis, which is going to give you giant cell tumor. And remember, these giant cells, they are going to resemble as you have like soap bubbles within the epiphysis, right? Simply you can see it resembles soap bubbles, right? Hello?
Yes.
Yes,
Yes,
right.
Yes.
Okay.
Yes, sir.
So on X-ray, whenever you see soap bubbles, you should just go for giant cell tumor. And what's the location of giant cell tumor? Epiphysis, right? It's very high. Epiphysis, soap bubble appearance on X-ray, right? And it's like locally aggressive as well. Is that clear?
Yes, sir.
So
Yes,
you
sir.
have two take-home points. It occurs in the epiphysis. You're going to have a UWorld MCQ on that as well. Epiphysis, and it's going to be like appearing as soap bubbles and epiphysis on your X-rays. That's simple, right? Giant cell, big like multinucleated cells. Okay, let's discuss our next tumor, that is Ewing sarcoma, right? So you have a lot of UWorld MCQs on Ewing sarcoma as well. Can anyone just tell me, is it a malignant tumor or a benign tumor?
Malignant.
Malignant.
Perfect. As we have sarcoma, so it means it would be a malignant tumor, right? Okay, can anyone just tell me something about Ewing sarcoma? Because like it's let's just give it a little bit importance and let's discuss it. What do you guys think? What is Ewing sarcoma? And like what are the characteristic features? What are we going to see on biopsy?
We're gonna see small blue cells.
Perfect. So
Small blue
okay,
cells.
perfect.
They will like, and moreover, we're gonna see onion skin. Onion skin.
Perfect. We are going to have onion skin appearance as well. Okay.
And moreover, they will grow in the diaphysis of the long bones.
Okay, perfect. Okay, so about onion skin appearance, if you remember, we were seeing onion skin appearance in another condition as well. We discussed in cardiovascular. Anyone, do you guys know that?
Yes.
Onion
Hyaline
skin.
cartilage.
Sorry?
Hyaline cartilage.
Hyaline
Hyaline.
cartilage?
Like
Hyperplastic
Arteriolosclerosis.
That was hyaline cartilage or hyaline arteriolosclerosis?
hyaline arteriosclerosis.
Okay, perfect. That's perfect. Okay. So Ewing sarcoma. What happens in Ewing sarcoma, basically, it's basically a tumor which is like the tumor cells are derived of your neuroectoderm, right? Neuroectoderm. So it's a malignant proliferation of poorly differentiated cells from neuroectoderm. Very important, very high yield, right? Okay, so it occurs at diaphysis, right? What's diaphysis? You already know that. For example, if this is our bone, okay, let me just draw your bone. For example, if this is our bone, we already discussed, we have a growth plate, right? We have an epiphysis, we have metaphysis, and we have diaphysis, right? So what we are going to see in Ewing sarcoma is that we are going to have neuroectoderm cells which are going to proliferate, and it's going to like go inside. And from the inside, what will it do? Okay, we also have a periosteum there, right? You guys already know that. I just keep on telling you guys again and again, right? So what would it do? It would just, this type of cancer or a malignant cancer or a malignant tumor, it would just produce a lot of bone, right? And like it would just spread like that. And your periosteum also have ability to regenerate your bone, remember, right? So whenever we have fracture, so it's your periosteum which is regenerating your bone, remember, right? So it have regeneration or regenerating capability or capacity, right? Regeneration, your periosteum. So what would happen that as the tumor is spreading laterally, so this periosteum is going to lay down more bone, right? Again, the tumor is spreading, so it would just lay down more bone. And if you just see this, you know, like the cross section of this bone, so you would just see a layers, right? Which would resemble an onion skin. Is that clear? Hello?
Yes, yes, clear.
So we are going to have onion skin appearance on X-ray. What's the reason of that? As the tumor is growing like outward, simply you can think of periosteum is going to lay down more bone, right? So ultimately you are going to have onion skin appearance. Is that clear?
Yes,
Sure.
clear.
Yes, sir.
Okay. And if you just see these cells on biopsy, you're going to see that these are round small cell, and it would be like blue in color, and it would resemble lymphocytes, right? But an important differentiating feature, like you can differentiate it from lymphoma, because in lymphoma we can also have like such blue kind of cells. So what's the main differentiating feature? They'll be giving you that it's associated, Ewing sarcoma is basically associated with 1122 translocation. You have a UWorld MCQ on that as well. Is that clear? 1122 translocation, just memorize it. High yield, it's a high yield, right? Is that clear?
Again, this point.
Yes,
Yes,
doctor.
clear.
Hello? Hello?
Yes. Yes.
Okay. As I told you, for example, if you're taking biopsy, right? Let's suppose if I'm just taking a biopsy. On biopsy, you are gonna have blue cells, and blue cells, they would just, resembles like lymphocytes, right? So in lymphoma, we discussed that lymphocytes can grow. They would just appear like blue cells on your biopsy. That can grow. They can just give you lymphoma, which is enlargement of your lymph node. We already discussed that, right? Non-Hodgkin lymphoma, Hodgkin lymphoma, everything. Remember?
Yes.
Lymphocyte rich, lymphocyte depleted, and everything. We discussed that, I guess. Okay, so how to differentiate? In the question stem, they must be giving you like something about like onion skin appearance, or they'll be just giving you history related to bone, or the third thing they'll be telling you that we have 1122 translocation, right? So this 1122 translocation of, sorry, any
I get
questions?
it. No,
Okay, perfect, right? Okay, so this was all about bone tumors. Let's just move to cartilage tumor, right? So again, we have our first cartilage tumor, that is chondroma. Can you guys just tell me, is it a benign or is it a malignant tumor?
Benign.
Benign.
Okay, what would be the name of malignant tumor? Chondrosarcoma. Perfect, right? So related to chondroma and chondrosarcoma, there are certain features which you guys should know, right? So it's basically a benign tumor, and chondrosarcoma is your malignant tumor. Remember, whenever we have cartilage tumor, they always occurs in the medulla, right? You know what is medulla? Remember, we have our bone, we have medulla, in which we have our hematopoietic stem cell bone marrow, right? And we have cortex, right? So all of the cartilage tumors would occur in the medulla of your bone, right?
Yes,
Hello?
we got it.
But an
Yes.
important point about benign, another important, both of them, occurs at the medulla of your bone. But for the benign, you should remember that it tends to occur in the extremities, mainly, right? Extremities. What do I mean by extremity? Like small bones of your hand and feet, right? While the malignant variant of this tumor, that is chondrosarcoma, would occur in your axial skeleton. What do I mean by axial skeleton? Like in the pelvis or somewhere centrally, right? Is that clear? Still, it would be in the medulla. Is that clear?
Yes.
Hello. So you
Could
have
please,
you
could,
would
could you please come again?
okay.
Regards location.
Okay, no problem. So we discussed that we can have like tumors of your cartilages as well, right? So again, we are going to classify it as benign and malignant. So benign tumors would be called as chondroma, while malignant are called as chondrosarcoma, right? Whenever you have cartilaginous tumors like either chondroma or chondrosarcoma, they would just occur in the medulla of your bone, where you have your bone marrow, right? Hematopoietic stem cells. Is that clear?
Yes. Yes.
It's common for that. But what's another differential? Another differential is when the benign tumors tend to occur in your extremities, small bones of your extremities. For example, like in your metacarpals, right? You can have like in the medulla of metacarpal, if you see a tumor, it would be chondroma, simple,
Okay. Okay, sir.
right? But if in the
Yeah.
axial skeleton, for example, in the pelvis, like for example, if you have pelvis and you have your like a tumor in the medulla, it's a chondrosarcoma. Okay,
Okay.
that's all which you guys have to remember. You have a U-word MCQ on that. They're going to give you a picture of this, the metacarpal bones, in which you are going to have like tumor within the medulla. So simply you can think of it's a chondroma. Simple. Right? Hello?
Yeah.
Yes,
Right.
doctor.
Yes, doctor.
Okay,
Thank you.
perfect. So it was all about tumors. Let's discuss something about joints as well, right? So we have joints as well. Okay, so we know what is joint. Joint basically is connection between two bones. Can I simply say that?
Yes.
But we have different types of joints, right? So either the joints can be like solid joints. For example, in our skull we have joints right in between the sutures. They are like example of your solid joint. You cannot move that joints, right? They are fixed. Is that clear?
Yes, clear.
And we also have synovial joints, which we discussed in knee section, if you guys remember, right? Synovial joint. And what's like special about synovial joint? Like synovial joint, we'll be discussing the anatomy again, but the main feature of synovial joint is that we can have like a big range of movement in your synovial joints, right? For example, like you can have extension, you can have flexion, while in the solid joint, you cannot perform any movement there. That's simple, right? Okay, we discussed that bone, B, O, and E. You have type 1 collagen, right?
Yes.
What about cartilage?
Type 2.
Perfect, type 2. So let's call it as cartilage, right? So cartilages basically have type 2 collagen. Is that clear? Hello?
Yes.
Okay.
Yes, it's clear.
Okay.
Clear.
So let's discuss our knee joint again. We already discussed that, for example, if this is our femur, so what happens? It's going to be attached, let's suppose, here with your tibia mainly. We discussed that we have a cartilage which is surrounding your bone, which is known as articular cartilage. Remember, we have an articular cartilage, and this joint is surrounded by a joint capsule, right? Hello?
Yes.
So we have
Yes,
articular
sir.
cartilage, and we have a joint capsule. This joint capsule, like the inner portion here, like it's basically lined by a structure or a connective tissue which is known as synovium, right? Right. And what's the feature of this synovium?
Yes.
Synovium. This synovium have the ability to make a fluid which is known as synovial fluid, right? Synovial fluid mainly consists of hyaluronic acid, right? Hello?
Doctor, right,
Yeah,
right.
yes, and this synovium, okay, just give me a second, please, just give me 1 second. Hello, can you guys hear me?
Yes, we can hear you.
Okay.
Yes.
Okay, so
Yes.
basically this synovium is going to make hyaluronic acid, and what's the goal of that synovial fluid? It's going to lubricate your joint, right? For the lubrication purposes. Why? Because we have a lot of, a big range of movement, so we need a lot of lubrication there at the joint space as well. Is that clear?
Yes,
Okay,
clear.
perfect. Perfect. So let's discuss our first pathology, that is osteoarthritis. So you're going to have a lot of MCQ on osteoarthritis, osteoarthritis or degenerative joint disease, right? So whenever you see the term osteoarthritis, or whenever in the question stem you see osteoarthritis, think that osteoarthritis is associated with age, right? So you're going to have osteoarthritis, which is basically inflammation of your joint. I'll be just discussing that, right? It can lead to inflammation, by the way, right? Okay, so it's basically associated with age. What do I mean by age association? That this pathology is mainly associated with wear and tear. So if we have an individual who is like having 70 or 80 years of age, it means that he would be having more wear and tear as compared to a younger individual, right? And this wear and tear of the joint can, like degenerate your articular cartilage. And as the articular cartilage is degenerated, the bone can rub against bone, and which can give problems. Is that clear?
Yes, clear.
Yes, sir.
Okay, perfect. Another thing in your questions, which you guys should just note, that if this pathology is associated with wear and tear, what do you guys think? If I'm just using the bone, or if I'm just using the joint more, what do you think? Will the symptoms be aggravated, or would it be relieved? Relieved, or
Aggravated.
Okay, perfect. So if it's associated with wear and tear, so in the question stem, whenever you see that we have an individual, once he wake up, his joint was stiff, no problem. But in the end of day, all of the symptoms were worsened, right? So whenever you see such kind of statement, think of osteoarthritis going on there. Is that clear?
Yes, sir.
Okay, perfect. So it means that when we are using the joint, or simply when you're using, or we are walking more, so in the end of day, all of the symptoms are going to be worsened. Is that clear?
Clear.
Yes,
Okay,
sir.
perfect. If it's associated with wear and tear, so there are a lot of features associated with that as well. Like we can associate it with obesity, right? For example, if you have an obese individual, it means he'll be having more weight on his joints, and it would further, worsen the wear and tear process, right?
Yes, right.
That's
So
correct.
can I say that obesity can be one of the risk factor?
Yeah.
We already
Yes.
discussed age comes on the top, right? The second one can be obesity, right? Third can be trauma, right? For example, if you have trauma to this joint or trauma to the articular surface, again, it can be one of major risk factor. Is that clear?
Yes.
Yes, sir.
Okay, perfect. So this degenerative joint disease, let's discuss what would be the location, right? In which location most probably we are going to have osteoarthritis going on, right? So the location is basically, you can see it in hip joint, you can see it in lumbar spine, right? Because all of these areas are, prone to weight bearing exercises. If you are just bearing weight, so most of the impact is going to be, like experienced by your lumbar spines, right? Your knees, as we discussed. Are you guys just following me? Hello?
Yes, we are
Yes.
following.
Yeah, we follow you.
Okay, perfect. Another point which you guys should remember, it can also, be seen, the osteoarthritis can be seen in distal interphalangeal joints and proximal interphalangeal. Very important, you guys should know that, right? So for example, if we have joints DIP and PIP, that is proximal interphalangeal joints. So what happens if you are using them, if you are just having a lot of wear and tear, we discussed that this articular process or articular cartilage, it can undergo degeneration, and the bones can rub against bones. So when the bones are rubbing against bones, so again we can see reactive bone formation, right? So the bone simply would react to this phenomena if you are just rubbing bone against bone. So you can see an extra bony outgrowths there, which are basically known as osteophyte formation, right? Osteophytes. Is that
Yes.
clear?
Yes, sir.
If I do not have articular cartilage, if I'm rubbing bone against bone, right? So we are going to have reactive bone, or, like some extra bone formation. So it would just, protrude out of your bones here, and it would just resemble, like a spikes upon the bone, which are basically known as osteophyte formation. Is that clear?
Yes,
Yes, sir.
So you're going to have a UWorld MCQ. They are going to simply give you an X-ray picture in which you have bone, and we have these spikes on the surface of bone which resemble osteophytes. They'll be telling you that which pathology are we discussing here. So that's simply your osteoarthritis. Is that clear?
Yes, sir.
Okay, perfect. right? Okay, so so whenever these osteophyte formation occurs at your DIP and PIP, like that extra bony outgrowth, so it can result into formation of nodes within the DIP and PIP. So here is question for you guys: if we have that nodes or that extra bony outgrowth in DIP, what's the name for that? What's the name for those nodes?
nodes.
Okay, which nodes?
Haberden.
But
Okay,
then
perfect. So they are known as Haberden nodes, and if the nodes are present in the proximal interphalangeal joint, they're basically
Bouchard.
perfect. They are known as Bouchard nodes. Perfect, right? So it was all about your osteoarthritis. Is that clear?
Yes, doctor.
yes,
Yes,
sir.
sir. Thank you.
Okay, there is also another term used, like for example, if I already discussed that this articular cartilage, due to this wear and tear process, it can be damaged, right? So sometimes what happens, these small fragments of that damaged articular cartilage can just come in the joint space, and once that like small fragments of articular cartilage are present within your joint space, they are simply known as joint mice, right? Joint mice, like small mice, or moving here and there in your joints. Is that clear?
Yes,
Yes,
doctor.
sir.
Yeah. Please repeat that one.
Okay. As we discussed that it's osteoarthritis, it's associated with wear and tear, and ultimately your articular cartilage is going to be damaged, right? It's going to be degenerated, right? So once the articular cartilage get degenerated, so some of the fragments of articular cartilage can come out in the joint space, right? They'll be moving these like degenerated articular joint fragments moving here and there in the joint space. And once they are present there, we are going to call it as joint mice. Is that clear?
Yes, doctor.
Okay, perfect. So let's discuss our next pathology, which is your rheumatoid arthritis. Very high yield. You're going to have a lot of MCQs in your work. And I think you guys already have an idea of rheumatoid arthritis because it's like, I would say, highest yield topic of entire MSK. Rheumatoid arthritis. As it is an arthritis, it means it's an inflammatory bone condition, some kind of, right? Can I say that? You're going to have some inflammation,
Yeah.
right?
Yes.
Okay, perfect. Okay, so it's rheumatoid arthritis. Is it an autoimmune disease? Yes or no? What do you guys think?
Yes, yes,
It's
yes.
autoimmune.
Yes, it is.
Okay, perfect. It's an autoimmune, right? We already discussed autoimmune diseases are mostly seen in women or men. Yes, what do you guys think?
Woman.
Women.
Women.
Perfect. You're going to see it in women mostly, right? What's the hallmark? It's an inflammation. So question should arise, inflammation of what? You already know A not B. So let me just tell you specifically, right? So for example, again, if this is our knee joint, let me just draw it again. You have your articular cartilage, and articular cartilage, you have your joint capsule, and we have our synovium, right? Okay, let me just draw synovium with green. We have our synovium. So it's basically an inflammation of your synovium, one of your MCQ. Synovium get inflamed. Is that clear? Hello?
Yes, sir. Clear.
Yes, yes.
Okay, for example, if you have an inflammation going on there, we already know that in the end of inflammation, we are going to have a recovery phase, right?
Yes.
In the recovery phase, like for example, if I just cut your skin, right? So you are going to have a recovery phase, and ultimately you are going to see formation of a granulation tissue, remember?
Yes.
What is a granulation tissue? It would be like a kind of tissue having a lot of blood supplies and some myofibrils, right? Is that clear?
Yes, clear.
So can I say that if I have inflammation of the synovium, so in the end again, you're going to have granulation tissue,
Oh,
Yes,
yes.
right? Hello?
Yes, yes, we are with you.
Okay. We know that granulation tissue have a lot of blood supply, but it also have myofibrils, right? What are myofibrils? Myofibrils basically tend to contract. It have ability of contraction. Can I say that?
Yes.
So if we have a lot of inflammation, and in the end of inflammation, we have a big, a big kind of, I would say, granulation tissue. It have myofibrils, which would tends to contract. So can I say that these myofibril contraction, what would it do? It would contract both of the joint, and ultimately the joint space is going to be decreased. Can I say that?
Yes, doctor.
Yes, sir.
Okay, perfect. Like if the contraction of myofibril is in this way, it would decrease the joint space. One of your UWorld MCQ. And collectively, what's this called? What's this granulation tissue called here? Is specifically in rheumatoid arthritis. It's known as pannus formation. Pannus formation. So you have a UWorld MCQ on that as well. So these myofibrils can contract. It can decrease the joint space. But what if the contraction is in opposite direction? Like for example, if these myofibrils are contracting this bone, like the femur, like in your small hands, let's suppose, right? In this direction, and these bones in this direction. So can I say due to this irregular contraction, what happens? We can see disrupted kind of fingers if it's in proximal PIP or DIP. Can I say that?
Yes, sir.
So you have the fingers would be like a kind of some going here and there, right? And so you have a swan neck deformity. If you guys remember, it would resemble like a swan neck, right? Hello.
Yes, sir.
Yes.
Okay, so why are we going to see swan neck deformity in rheumatoid arthritis? The idea is very simple. In the pannus formation, you have myofibril. It would just contract. It would just pull off your bones in opposite direction, and it's going to lead to that swan neck deformity, right? You have a UWorld MCQ on that as well. Is that clear?
Yes, doctor. Clear.
Okay, perfect. So,
Sorry,
if
doctor,
it-
can you please repeat? Sorry, please.
okay, no problem. Like for example, let's suppose, okay, if these are, for example, I'm just drawing fingers of an individual who is having rheumatoid arthritis, right? So let's suppose these are his distal interphalangeal joints and his proximal interphalangeal joints, right? Hello?
Yes.
Let's suppose if I have a pannus formation here, if this individual is having, okay, let me just repeat the entire story. We have an autoimmune disease, inflammation of your synovium. In the end, we have formation of granulation tissue, which is going to be called as pannus formation. In the pannus, we know there are myofibrils which tend to contract, right?
Yes, right.
doctor.
Okay, like for example, if these are our bones, if some of the myofibrils are contracting this, this phalanges in this way, and like the metacarpals, these bones like in opposite direction. So what happens? All of the anatomy of your finger is going to be disrupted. Your fingers are going to be appearing as disorganized, moving here and there. Okay, let me just show you the picture in the end. Okay. Okay, you can just see the picture of rheumatoid arthritis. You can just open it. So you have like a irregular kind of fingers, right? Is that clear?
Yes, doctor.
Okay. And for example, here again, you have pannus formation. The myofibrils are, pulling these interphalanges in this direction and in disrupted way. So your finger can, tilt like that, right? Which would just result in swan neck deformity, right? So it's basically due to pannus, and inside the pannus, you have myofibrils, which are causing this problem. Is that clear?
Yes.
Yes,
Clear.
doctor.
And we also have joint space nerving, right? We also discussed that. Okay, so if it's an inflammatory condition, so simply you can think of inflammation, like for example, in the morning, what would happen? If a person is sleeping, this inflammation or inflammatory cells, simply what would happen? The inflammation is going to be more at the night, right? So once this individual wake up, he'll be having a lot of inflammation, a lot of problems. But as he's just using these joints, as he's using his fingers, all of the inflammatory debris, it would just move here and there, and it would leave the joint space. So the idea is that with movement or with activity, the symptoms are going to be reduced. Is that clear?
Yes, clear.
Yes. So the idea is simple. Like simply you can imagine, like for example, if an individual is having sore throat, so in the morning he's experiencing a lot of problems, right? But with time, as he's just talking and using his vocal cords, so all of the inflammation subsides, and ultimately he's going to have some relief, right? So simply you can think of.
Yes.
So what's the importance of that? You can just compare it with osteoarthritis. In osteoarthritis, whenever you see in a question stem that if an individual is using his joints and with time, the symptoms are worsened, think of osteoarthritis going on. If the symptoms relieve with activity, think of its rheumatoid arthritis. Is it clear?
Yes, clear.
Okay, perfect. So if it's an inflammation, we already know we are going to have some symptomatic, like some systematic signs as well, like for example, fever, malaise, weight loss, and myalgias. Is that clear?
Yes.
Okay, so what is the lab finding? Lab finding is very important. Like as it is an like autoimmune disease, so what are we going to see? We are going to see rheumatoid factor. Rheumatoid factor. What is rheumatoid factor? Very important. You have a lot of MCQs on that. It's basically IgM against FC portion of IgG. I think we all have done our immunology and you guys are better aware of that term which I have used, right? Like for example, if this is your IgG, so you have your FC portion. So what is rheumatoid factor? You're going to have IgM against FC portion of your IgG, right? And collectively it's known as rheumatoid factor. Is that clear?
Yes.
Hello?
Clear.
Okay. Another thing which you guys should just keep in mind, for example, if we have inflammation going on, so there would also be a lot of inflammatory cells, right?
Yes, right.
Like for example, if I'm just taking some of the fluid here from an individual who's having rheumatoid arthritis, so there will be a lot of neutrophils as well, right?
Yeah.
Okay. So the presence of neutrophils is very important, right? And another thing, is it a chronic condition or acute condition? What do you guys think?
Chronic.
So it's a chronic disease. And hematology we discussed. If whenever we have a chronic diseases, chronic inflammation can also lead to, yes.
Anemia of chronic disease.
Perfect. Like you can have acute phase reactant that is hepcidin. It can sequester all of the iron within your ferritin stores, which can lead to iron deficiency anemia. That is anemia of chronic disease. Is that clear?
Yes, doctor, clear. Sir.
Okay. Okay, perfect. So I think it was all for today. And tomorrow we are going to discuss the remaining pathologies. And the time is finished. Like I have just, I'm done with my 1 hour. Okay, so day after tomorrow, we are going to have a boot camp session. Hope so you guys enjoyed today's session. And by the way, why am I seeing so less people in the class? Only 54. It used to be 71.
No, there were 60, 55 something, but I don't know. Just now they decreased.
Okay, so I think it's problem with time or what? We can just manage that.
Yes, sometimes somewhere is iftar or like
Okay, no
Doctor.
problem, no problem.
the time.
Hello?
Doctor,
Yes, please.
yeah, this is my first day with you guys. So I just
Okay.
want to know what about the task? There's no task for today.
Okay, so actually, if you're new, let me just guide you a little bit. So we have just made this group that is USMLE family. So we basically, are you added in the group? Hello?
Yes.
Okay, so we'll just add you to the admin group, and there you are going to have tasks. Like basically here we have decided that first of all, we are going to have lectures, and right after that, you guys are going to do your task, right? And in your task, like in the UWorld MCQ, Dr. Mahin is going to do the UWorld MCQ, and all of the MCQs are like you're going to have like maximum of 30 to 40 MCQs per day. Dr. Mahin is going to do like the half of your task with you guys, and like in the end, you guys will be just doing the remaining tasks in your Discord session, right? So like this is the way which we are following here, right?
All right. Thank you so much.
Okay. So were you there in the Dr. Mahin session?
Yeah.
Okay, perfect. So as you have already done 20 MCQs, so 20 MCQs are remaining. So right after the class, normally which we we do is that we are going to have like 15 to 20 minutes of break, and then like all of the participants join the Discord server, and there I'll be just sending you the link of Discord. Don't worry about that. And the remaining 20 MCQs, you guys are going to do it by your own, right?
All right. Thank you.
Okay, thank you so much. Hope so you guys enjoyed the lecture. Thank you so much. Have a nice day. Bye bye.
Thank you, Doc.
Thank you. Bye.
Thank you. Bye. Bye.